Very good evening to all. Uh, First, I would like to thank Speedcon team for giving me this opportunity. So today my talk is based upon this case. So let's start with the case only. So here is a 55-year-old male patient with history of pre-diabetes for 5 years, and he's also a hypertensive for last 5 years. He has come to you for a follow-up visit. He complains of some dyspnea on exertion grade 2. His antihypertensive medications have been gradually stepped up over the past 2 years, and he's currently taking telmisartan 40 mg twice daily, amlodipine 5 mg twice daily, hydrochlorothiazide 12.5 once daily for hypertension, and is also taking a statin. He also admits that he has trouble keeping a track of his medications because of so many medications. Sometimes he tends to forget to take the medications. On examination, he is obese with BMI of 27.2. His blood pressure in the clinic is 170 by 100 millimeters of mercury. His pulse rate is 83. And his previous BP recordings also shows whenever he has visited, his blood pressure has always been recorded high, 160, 100, 180, 96, 170, 90. On lab investigation, he has mildly reduced EGFR with fasting plasma glucose of 105, HbA1c of 6.1. Sodium 140, potassium 4.5, LDL 92, and high triglycerides of 260. So this is a routine case which we see in our daily practice. 55-year-old male who is pre-diabetic, hypertensive, dyslipidemia, and obesity. But the real roadblock here is the persistently high blood pressure in spite of increasing the medications. So this is the real roadblock, so what to do? The questions which arise in our mind whenever we see such a case is, first of all, what is his goal BP? What are we aiming for? Secondly, does he have a resistant hypertension? Third, what can be the causes of his uncontrolled blood pressure? And lastly, how to evaluate and what to do and approach in such a case. First, looking at the goal blood pressure, there are many guidelines and every guideline has its own take on it. The American Heart Association and European guidelines, they go for a blood pressure target of less than 130/18 in all the categories, being the last category being the no comorbidity, or even if the patient has high cardiovascular morbidity or the patient has diabetes, kidney disease, all they are recommending less than 130/80. The ADA guidelines, which we follow for our diabetic patients, they recommend a target of less than 140/90, but again, they also say that if the patient has high cardiovascular risk, then aim for a lower blood pressure of less than 130/80. So broadly it is, if the patient has higher cardiovascular risk, you are aiming for a strict blood pressure control of less than 130/80. A low cardiovascular risk can go for less than 140/90. So in our case, has pre-diabetes, dyslipidemia, hypertension, obesity, high cardiovascular risk, we will aim for a blood pressure of 138, less than 130/80. So this figure shows the classification of hypertension based upon the office blood pressure measurements and the number of medications which the patient is taking. So if you see in the colored, the yellow and the red colored here, more than 140/90, if you're taking the target here as this will be then uncontrolled blood pressure. Up to 2 medications, we'll call it uncontrolled. The moment the patient has started taking 3 or more than 3 medication, we label it as resistant hypertension. More than 5 or equal 5 medication, we call it refractory hypertension. On left hand side, we have green boxes where we have controlled hypertension less than 140/90, up to 3 medications. But even if the patient is taking more than 3 medications, and it is controlled, it is called controlled resistant. The patient will be still qualified as having resistant, but that is a controlled resistant hypertension. So this is a classification mainly based upon the office BP, blood pressure medications, and blood pressure measurement and the number of medications. So resistant hypertension is defined as BP that remains above goal in spite of concurrent use of 3 or more antihypertensive agents of different classes. If tolerated, one of the 3 agents should be a diuretic, and all agents should be prescribed at maximum recommended or at least maximum tolerated doses. That is what is called as definition of resistant hypertension. Now, one question which arises in our mind that after going through this much, that which one of the following is the key component for the diagnosis of resistant hypertension? Is this the grade of hypertension, or increased out of office blood pressures, or number of antihypertensive medication, or is it the non-dipping status of ABPM. How many will go with answer 1? We can just raise our hands and quickly a poll here. Answer 2? Anybody wants to go with answer 2 here? No answer, okay. Answer 3? Okay. Answer 4? Okay. So we have a lot to do, have a lot of work to do. Answer here is number 2. We need to document increased out of office BP measurement to label a patient a case of a true resistant hypertension. So this is clearly seen in this figure here, that if you see a broad spectrum, we have uncontrolled hypertensive patients on treatment. Out of this, we have few percentage of patients who have apparent treatment resistant hypertension. That's what the definition which I just showed in a previous slide. That is what is called apparent treatment resistant hypertension, that we are measuring the office BP. We know that patient is taking 3 or more drugs and not controlled. But out of these apparent treatment resistant hypertension, we have large chunk who have pseudo resistant hypertension, and at the end we are left with 10% of patients who have actually true resistant hypertension. So the next question which I was discussing, does this patient have a resistant hypertension, has to come from this. What all is to be excluded first to label a patient as a case of a true resistant hypertension. So pseudo-resistance can occur because of various reasons. One of the very common reason is white coat hypertension. That is, you're measuring the high blood pressure high at your clinic. Poor office BP measurement technique. I'll come back to the first 2 points in little detail in the subsequent slides. Poor adherence to the prescribed medication. This is very, very important, that we need to go into history in detail, asking about how is the adherence. Obviously, patient is not going to come on its own, that patient is missing on the tablet. Maybe the direct questioning like, how many tablets did you miss in last 1 week or last 1 month? When did you buy a new strip of medications? Or are you really experiencing any adverse effects? Many times patient will have suddenly low blood pressure, patient will leave the medication and blood pressure is high, will start taking again. So there are multiple factors which will affect the adherence, the cost. Patient is not able to afford it, it's not coming out of it. So these things have to be clearly looked into, whether the patient is really taking the medications or not. Marked brachial artery calcification can also lead to falsely high blood pressure. Clinical inertia, clinician inertia of the physician, that physician is not adding on to the bone medication, is also very, very important. So this is the figure showing the estimated prevalence of each of these causes. As you can see, under treatment is accounting for very high percentage of cases of accounting for the higher prevalence of cases of pseudo-resistant hypertension. Along with that, we have medication non-adherence. Let me just focus upon these 2 factors also. So accurate BP measurement techniques is must before we go on and label the patient as uncontrolled or resistant hypertension. There's a huge checklist here on the left hand side. If we see, there are 6 steps here, multiple pointers, but broadly, even if these 8 things are taken care of, that patient, that when you start taking blood pressure, first of all, for initial 30 minutes, patient should not be exercising, no coffee, and should be sitting for at least 5 minutes, should not be talking while taking blood pressure, support arm at heart level, put the cuff on bare arm, use correct cuff size, support the feet, keep legs uncrossed, have empty bladder, and support backs. Even if these parameters are taken care of, we will get a good amount of accurate blood pressure, and this is very, very important too. And in fact, one study, it was shown that if the blood pressure was taken by a nurse or technician and not by the doctor, also had shown a better result. So the importance of out-of-office measurement in the terms of by using ambulatory blood pressure monitoring and home blood pressure monitoring is to distinguish and identify these 2 very important hypertension, the white coat hypertension and the masked hypertension. The white coat is when you find elevated BP in the clinic but controlled BP when measured by ABPM or HBPM, and masked is whenever you find elevated BP when outside the clinic by ABPM and HBPM, but when it's controlled at the clinic. This is another very important entity. The pointers are, if the patient is not having much of end organ damage, and you're finding every time the patient is coming to you at the clinic high BP, that's pointed towards white coat hypertension. But you are finding that patient is having end organ damage, but the BPs you're showing in the clinic is controlled, that's pointed towards masked hypertension. Besides having diagnostic value, it also has a prognostic value. ABPM has been shown to be a better predictor than the office measurements for cardiovascular morbidity. So therefore, this is how the ABPM is being done. This patient, for almost 24 or it's put there every 15 to 20 minutes BP cuff is inflated during the daytime, every 30 minutes at the night time. What we get is mainly four values: average daytime blood pressure, average awake time, average night time, and we also look at the dips at night, because usually the dip in the blood pressure is around 10% dip in the systolic blood pressure. If it is not dipping at night, these are called non-dippers, which are again prone to have more cardiovascular morbidity and mortality. So based upon ABPM, then we have four categories here. If you look at the white coat hypertension, if you see the office blood pressure, it is not controlled, but by doing ABPM, we have targets different. By ABPM, daytime BP is well controlled, night time. So these are the blood pressure goals as per ABPM. When you're finding that the office BP is controlled and ABPM is also finding it is controlled, it will be sustained control resistant hypertension. When you're finding that office BP is high and also ABPM is showing high, both daytime, either daytime or nighttime, any of these if it's coming high, then it is a true resistant hypertension. And masked hypertension, in the office you're finding a less BP, but on ABPM you're finding a high BP. So this is how we can find out from the value of ABPM in diagnosing a case of true resistant hypertension. Problem with ABPM, it's expensive, not many people can afford it, therefore home blood pressure monitoring is a very good alternative to this, and many guidelines have actually endorsed it. But again, with this also we need to have a clear guidelines what is to be done. The blood pressure measurement technique has to be taught to the patient. At least 7 days record is needed, in which patient will monitor twice a day blood pressure, one in the morning between 7 to 10 a.m., another at the daytime between 1 to 10 p.m. 2 readings in the morning, 2 readings in the evening, and the patient will come back to you with this kind of record where you can assess whether the patient has uncontrolled or resistant hypertension or not. So once you have established that the patient has now resistant hypertension, what is the etiology of it? 3 main categories are there: lifestyle factors, medications, and secondary hypertension. Lifestyle factors are very, very important. Majority will have lifestyle factors which are accounting for the resistant hypertension, and these are the first one to be corrected before we move on to adding more medications. Obesity is a well-known factor for the high blood pressure. Not only the high BMI, but even the high visceral adiposity can also lead to the high blood pressure. Dietary sodium has been clearly shown to be linked with the high blood pressure, and in fact reducing the daily sodium intake to less than 100, which is equal to 6 grams of sodium chloride per day, has been shown to cause a significant reduction in the blood pressure. So careful dietary history is required, how much salt patient is taking. Alcohol, moderate alcohol consumption is still controversial, but clearly heavy alcohol intake has a well-established risk factor for hypertension. Physical inactivity, no doubt, contributes to hypertension. And sleep deprivation, this is another important parameter which we tend to forget. We don't ask in the history, so one should frequently ask about the sleep quality and duration, because sleep deprivation has been shown to cause even paroxysmal hypertension, which can mimic pheochromocytoma. So sleep deprivation is another lifestyle factor which we have to carefully look into. Coming on to the medications are very important. In any roadblock you face, you need to take a history of detailed medication history, what the patient is taking. The patient is coming to you, ask the patient to bring all the medications patient has or bring the list of it. NSAIDs have been shown to be clearly associated with high blood pressure because of effect on the prostaglandins, except for celecoxib. So one should have a detailed history whether the patient has been taking NSAIDs regularly for their body aches, pains, knee pain or anything. Oral contraceptives have been linked with hypertension, although postmenopausal therapy and HR replacement therapy has not been shown because of the low dose estrogen given there, but oral and contraceptive, that's why it's a kind of a relative contraindication in patients who are having hypertension. Antidepressants, both tricyclic antidepressant SSRIs have been shown. Corticosteroids, very important history. The patient must be taking steroids for many reasons, asthma, dermatological conditions, or alternative therapy the patient is taking, must obtain that history. Decongestants, a lot of patients are taking. Last one, tyrosine kinase inhibitor is another oncology patients coming to us. I've seen 2 patients on sunitinib, very high refractory hypertension, and sunitinib dose had to be reduced to get a good BP control. So medication history is very, very important. Before we jump to the conclusion that the patient has resistant hypertension, we exclude that the patient is not taking any of these medications. Coming on to the secondary hypertension, majority, 95% of the cases are primary or essential hypertension, but 5% can have secondary hypertension, out of which renal causes are the most common ones. The renovascular disease, You should suspect a renovascular disease if you're finding an unexplained creatinine elevation and or acute and persistent elevation in serum creat of at least 50% after you're added a ACE inhibitor or ARB or a renin inhibitor. A patient with diffuse atherosclerosis, or you have found a unilateral small kidney on ultrasound or asymmetry in the kidney size, then you should suspect onset of hypertension, the blood pressure of 160 of more than 160/100 after the age of 55 years, or if you're finding any bruit in the abdomen. That's where the importance of auscultation is here. Renal parenchymal disease, you must check for any creatinine elevation, abnormal urine analysis that will point to renal parenchymal disease. Obstructive sleep apnea is a very, very common condition. In fact, it's almost present in 70 to 80% of patient-resistant hypertension. So one should vigorously ask for the history of obstructive sleep apnea, asking for loud snoring or any witnessed apneic episodes, daytime somnolence, fatigue, because it has been shown that correction of OSA with CPAP leads to reduction in blood pressure. Coarctation of aorta is another one. That's the importance of checking blood pressure both in arms and legs and picking up this condition. Coming on to the endocrine causes, although they count with a very less percentage of secondary causes, but they're very, very important because they are treatable. If we pick them, if they treat it, we can cure the blood pressures. Common ones are the primary aldosteronism, FIO, Cushing's, acro, and thyroid disorders and others. My main focus today will be on primary aldosteronism. This is a condition in which aldosterone production is inappropriately high and it's independent of renin-angiotensin system. Patient will have hypertension. Patient may have hypokalemia, but majority, 50 to 70% of these cases have normokalemia. So this is not a classical feature of having hypokalemia, but if you have hypokalemia unexplained, that definitely points towards primary aldosteronism. Patient might be having a little bit of polyuria, nocturia. Edema is not common. Serum sodium can be slightly on the higher side. Patient will have target organ damage at an early age, and primary aldosterone has been shown to present in 20% of cases in confirmed cases of resistant hypertension. So this is the study from AIMS, which clearly showed that in 202 young hypertensives who were screened, primary aldosteronism was confirmed in 17% of cases, and among these cases, 51 had resistant hypertension. And out of resistant hypertensive patients, 41% had primary aldosteronism. This is clearly a very high prevalence rate of primary aldosteronism and resistant hypertension. Therefore, now it is recommended that all resistant hypertension patients should be screened for aldosteronism. The screening test is simple, that you go for checking the concentration of plasma aldosterone and PRA or direct renin concentration. Again, there is a huge checklist how to perform these tests, but then because of the chances of missing out on this condition, it has been recommended that even you can test this, even if the patient is taking Aldactone, the spironolactone, you can still go ahead testing, because as long as the PRA is suppressed, you can easily interpret the test. So go ahead with the screening test. A positive screening test is more than 30. You will go ahead with the imaging, and the treatment with either the mineralocorticoid receptor antagonist or unilateral adrenalectomy gives very good result. Pheochromocytoma, the prevalence is up to 4% in resistant hypertension cases. Familial syndrome present, a family history, or incidentally detected adrenal mass, patient having along with diabetes, all these are pointers. And the classical history, you might find a paroxysmal elevation of blood pressure associated with headache and palpitations and sweating. And surgery is the treatment of choice here. Cushing's, I would say that may not be a florid Cushing's present to you, but look for subtle sign like mooning of face. And this is a patient who came to us with taking exogenous steroids, some desi medications, and it turned out to be a case of Cushing syndrome. Simple test is just go for a screening test of cortisol in the 8 a.m. If it is suppressed, is exogenous. It is not suppressed, can be endogenous, and then you go ahead with doing further tests to confirm a case of Cushing syndrome. Acro count for very, very less, but do look for subtle acromegaloid signs like a supraorbital prominence. Look at the hands and feet. Definitely, you may ask for history of increase in the shoe size or tightening of the ring, which can give the pointers of acromegaly. There are other causes out of which I think thyroid disorders are the one which are very common. You must go into the history of that, or if you're finding any abnormalities in the thyroid function test, that can account for this. Primary hyperpara causing raised calcium can also account for the high blood pressure. For investigations, for etiology, you must go ahead with the renal function test, calculate EGFR, urine analysis. Plasma aldosterone PRA must be in all cases of resistant hypertension, and wherever indicated, as I discussed, these tests should be done. For end organ damage, you must again go ahead with looking for the kidney function, heart function, fundus, and other comorbidities. So this is my final slide. This is how we should approach. First, you confirm that the patient has treatment resistance. The first box shows that this is an apparent treatment resistance. Then you exclude the pseudo-resistant by confirming all those adherence and performing an ABPM. Then you look for assess the secondary hypertension causes, as I listed and as I mentioned. And finally, you also go ahead and assess the target organ damage. Thank you.
Thank you, Dr. Dotto. You took the trouble to tell everything. Thank you very much.
Thank you.